Thank you for having me. Let me pull up my slides. Excellent. So like Dalton said, it's nice to have a space and an opportunity to talk a little bit about the MPNs and specifically about bone marrow biopsies, because I think that they can be a procedure that can generate some anxiety. And so having a little bit of information about that and what to expect can be helpful. So for this audience, I'm not going to spend a lot of time reviewing this, but when we're talking about MPNs, we're talking about this group of blood conditions called myeloproliferative neoplasms. And the reason we're talking about bone marrow biopsies is because these conditions originate in the bone marrow. The bone marrow is the factory that makes the blood. And we get a lot of information about what's going on in the blood by looking at the bone marrow itself. And we can, unfortunately, for now, only do that by doing a bone marrow biopsies. There are mutations that your doctors will talk to you about that lead to the development of these conditions, such as the JAK2 mutation, CALR mutation, or MPL mutation. And these mutations exist and originate in the blood-forming stem cells that exist on the insides of your bones in the bone marrow. And so these mutations are basically the disease. They are one and the same. Okay. So there are three main types of MPNs. There's essential thrombocythemia, polycythemia vera, and myelofibrosis. And each of these look different when we do a bone marrow biopsy. And so the biopsies help us to better understand what's going on in the blood. So we have ET and PV. They each have different criteria for diagnosing it. And so in medicine, like in life, we like to organize things, understand how they originate, and keeps us organized so that we know how to think about like the approach to each patient. And so we have criteria that basically say, if you see the following, then you meet the criteria for this diagnosis. But if you don't see these things, then maybe it's this other diagnosis. And that's true for the MPNs as well. So just having high platelets or just having high red blood cells or just having a big spleen doesn't meet criteria for an MPN. And it's really important to be thorough about making sure that you meet criteria for a diagnosis, for a disease, because that really then sets the stage to ensure that the treatment that follows is the correct treatment. Same with myelofibrosis. Sometimes we're able to guess that somebody may have myelofibrosis, but really the bone marrow biopsy will tell us about the fibrosis, which is the medical term for scar tissue. And the only way to see that is inside of the bone marrow. Like I said, the bone marrow is where all of the blood is made, and so that gives us a sense of what's going on. Okay, so today we're going to talk about why we're doing a bone marrow biopsy, and also, how often do you need it? I get that question all the time. We'll talk about how to prepare yourself for the bone marrow biopsy, as well as maybe the future of diagnostic testing for myeloproliferative neoplasms. So like I mentioned, we need to do a bone marrow biopsy because the bone marrow, that space inside of the bones, is where all the blood in the body is made. And so sometimes blood cells, and when you get your blood checked, your blood may hint that something is going on with the bone marrow, but really the only way to confirm for sure what's happening is to look at the factory, see what's broken, see what you have too much of, what you don't have enough of. And then also kind of looking at the architecture, seeing, is everything where it's supposed to be in the right order. And really the only way to do that is to get a sample of the bone when you do the bone marrow biopsy. So what does a bone marrow biopsy actually entail? So there are two parts to the bone marrow biopsy. There is the biopsy itself, which takes, or a core, which takes a small amount of bone, really like about half an inch or maybe a little bit more. And it's very narrow, like just a few millimeters wide, that core. And then there's what's called the aspirate. So the aspirate is just a small amount of liquid sample, very much looks like blood, but it just has tiny little pieces of bone inside. Generally speaking, we do a bone marrow biopsy from the pelvis. The pelvis is that bone in our hips that is the broadest, sort of flattest bone in our body, and that's filled with bone marrow. And it's an easy bone to access because, getting a bone marrow from a femur or a humerus, something inside of our arms or legs, would be really difficult and extraordinarily painful. Whereas this bone is superficial. You can feel it if you feel the back of your hips, and makes it easy to access in the clinic. So the procedure itself really shouldn't take that long, and the results can be available in different time frames. So there's some information that can be available almost the next day or maybe a few days later, but there's some information that may take some time. The core itself, that little piece of bone, that's easier, and it needs to be processed, and then the pathologist look under the microscope and see what's in there. Are there too many cells, not enough cells? Is there some scarring? Are the cells not in the right order? Do they look funny? Is their shape not the right shape? Those kinds of things. That usually takes a few days. But then from the fluid, the aspirate, we send a variety of other tests that are genetic tests, that are more subspecialized, and that may take a little bit longer. But all of that together then gets put together into one report. And remember, the bone marrow is a sample of the blood that's being produced, and it gives us an explanation of what we're seeing circulating in your bloodstream. So why are blood tests not enough at diagnosis? So like I mentioned, the blood counts and the presence of these mutations strongly suggests that you have an MPN or that a person has an MPN, but they're not confirmatory by themselves. So in some instances, the bone marrow biopsy is more useful, and in some other instances, we can say, maybe you can skip it this time. And I think it's important to be aware of that. Sometimes the bone marrow biopsy really confirms the diagnosis. Sometimes the bone marrow biopsy really tells us very important information about response to treatment and those kinds of things, but sometimes it doesn't. And so I think as a patient, it's important to ask the doctor, how will this change how you think about my diagnosis? How does this change my treatment planning? Because I think it's just important to know why this is being done. And so, for example, if somebody has a new JAK2 mutation, the bone marrow can help us to distinguish between, let's say, polycythemia vera or essential thrombocythemia. With CALR, it can help us distinguish between ET and myelofibrosis. But sometimes we really do have a lot of information from the peripheral blood where we say, your blood counts are really, really high, you have a JAK2 mutation, most likely this is going to be polycythemia vera, and the bone marrow biopsy doesn't add all that much information. But if you have a new, for example, detection of a calreticulin mutation, the bone marrow biopsy is really the only way to distinguish between ET and myelofibrosis. So not to get into too many details, but important to know that the bone marrow biopsies are more or less useful in different scenarios. So I mentioned this. The bone marrow shows how many cells are in the bone marrow. So that's reported as cellularity. The older we get, the less cellular our marrow gets. That's the way the bone marrow ages. And so instead of having tons of cells that are making blood, you also have these little fat globules. So the marrow becomes less cellular and more fatty. It's just normal. In MPNs, usually we see marrows that are very cellular, which makes sense. We're producing a lot of blood cells, so the bone marrow itself has a lot of cells, a lot of cellularity. We also see the architecture, like I mentioned before, meaning, is everything in the right order? And does it look the right way? And then we see the scarring, and that can help to distinguish things like essential thrombocythemia from myelofibrosis, and also from this in-between entity called pre-fibrotic myelofibrosis. So it's helpful to establish a baseline, know where we're starting from, and really give us a more accurate diagnosis. Sometimes, though, it doesn't change the management. So sometimes I'll have a patient that's older or frail, or has lots of medical conditions, and maybe doing that bone marrow biopsy is really difficult. Listen, sometimes we just shouldn't get a bone marrow biopsy, and that's okay. But I think it's important to understand why we can do it and why to choose not to do it. So, important to know what we get from the bone marrow biopsy, but also important to know that There's some instances where it's not necessary. And then sometimes, I've had patients that show up with blood counts that look one way, and I'm like sure that the person is going to have an MPN, and then we do the bone marrow biopsy, and it really turns out to be something totally different. So it really does help to rule out other conditions that look similar. So what the biopsy tells us, so I talked a little bit about this, but I'll just repeat a little bit. So it tells us the cellularity, how much of the bone marrow space is made up of cells, because the rest is made up of fat cells, and that's okay. It's normal to have that. It also looks at the fibrosis or scarring grade. So this is an example of a bone marrow biopsy here on the left. And all those little black squiggly lines are fibrosis. And so if you see a little bit of fibrosis, the pathologist grades it as a 1+, and if there's an in-between number of fibrosis, they grade it as a 2, and if there's tons and tons of fibrosis, tons and tons of those black lines, and they call it as a 3+. So it gives us this grading scale of how much scarring is in the bone marrow. The bone marrow also is a great place to tell us how many of these immature or baby stem cells there are. We call those blasts. So all of us should have a few blasts because those are the blood-forming stem cells, but we shouldn't have a lot of them. So patients that have a diagnosis of, for example, acute leukemia, they'll have lots and lots of blasts. But it's normal sometimes in patients with myelofibrosis to have a little bit of an elevation in the blast count. So blast count percentage is really something that is important to look at in the bone marrow. And then, like I mentioned before, so that's all from the core, but from the aspirate, that liquid part, you can send it to get genetic tests. One genetic test is called a karyotype, that's on the right-hand side, where we get these, a picture of all of our chromosomes or all of our genetic information, and these like squiggly X-type lines, and that's basically what's called a karyotype, a picture of all of the chromosomes, and we see are all the chromosomes in the right place, are some missing, are some of them partially missing. So that's some information that we get from the aspirate. And it really works much better from the aspirate. Some tests we're able to do from the blood, but a karyotype is really better from the bone marrow. And then we can also send that aspirate for additional testing, most importantly, genetic testing to know, does a patient have a JAK2 mutation or other mutations? That test can be done from the bone marrow, but really just as easily and just as effectively, it can also be done from the blood. The bone marrow core can also tell us if we're missing iron. So sometimes, pathologists can say by looking at the bone marrow, is your bone marrow filled with enough iron or is it missing iron? Which can sometimes be important to help explain why people may have low blood counts. And another important thing with a bone marrow biopsy, so I talked about establishing a baseline, meaning you do a bone marrow biopsy of the bone marrow of the patient at the time of diagnosis. But let's say that things change over the next couple of years, or you do different treatments and blood counts are looking different. A bone marrow biopsy can help us to distinguish a change from one condition, like let's say polycythemia vera, to another condition like myelofibrosis. These are related conditions. It's not like you have two diagnoses. It just means that one progressed or turned into the other. And so a bone marrow biopsy is very helpful in those situations. In other conditions, the bone marrow biopsies are done more frequently to really get a sense of response to treatment. And MPNs, or treatments, don't change the way the bone marrow looks that reliably. And so we're not in the practice of doing lots of what are called serial bone marrow biopsies to assess response to treatment. We usually just see how patients do based on their blood counts, and only repeat the bone marrow biopsy if we think that something's going on that's concerning. Patients that are on clinical trials are an exception to that, where the clinical trials themselves will mandate you have to have a bone marrow biopsy done at a year, or at 6 months, or et cetera. I will say, and this has been, I think, very encouraging, many of us that treat these conditions a lot have complained a lot about that, because we know that bone marrow biopsies don't give us that much information and they put our patients through a lot. So we've complained a lot about this to the folks that design these trials, the pharmaceutical companies. But there are also patient advocates now included in the development of many of these clinical trials. And so with that, I think there is more awareness and there's less bone marrow biopsies that are being mandated on trials. So anyway, lots of different reasons for doing bone marrow biopsies. So how often do you need one? Well, hard to really predict. It's not on a fixed schedules, like I mentioned. I think one place where I think is important to consider a bone marrow biopsy for almost everybody is at diagnosis. It gives us, like I said, a baseline, what's really going on, making sure that the classification of the diagnosis is accurate. And then I would say a bone marrow biopsy for patients with MPN really should only be repeated if there is something that is worrying your doctor or care team, thinking that they are transforming from one condition to another, or there's something unexplainable in their blood counts. I would not recommend doing routine bone marrow biopsies, putting patients through bone marrow biopsies just so that we can tell them, oh, it looks like you still have polycythemia vera. I don't think that that's good medicine. I don't think that helps the patients. So usually not a fixed schedule. So bottom line, bone marrow biopsy is a targeted, important diagnostic tool. It's not something we do routinely otherwise. It's not something that we say like, oh, it's been 3 years, it's time for your bone marrow biopsy. No, like I said, we do it for diagnosis. And then we repeat it as needed if things are changing. Blood counts are going down significantly. The spleen is growing a lot, and there's concerns. But I think it's really important, and I said this before and I'll say it again, to ask your care team, why are we doing this bone marrow biopsy? What information are we going to get from this bone marrow biopsy? And most importantly, how does this change how I get treated? If the bone marrow biopsy is not going to change how you get treated, and the information that your doctor or care team thinks you're going to get from this is not something that's very meaningful to you, it's okay to ask, and it's okay to say, you know what? I don't necessarily know that I want to have that bone marrow biopsy. Maybe you're in your 80s, maybe you just broke your hip, maybe whatever. There's all sorts of things that can happen where you can say, if that's not really going to change what you do for me, I really don't want to have that bone marrow biopsy. So I think really important to have a conversation and understand what you get from the bone marrow biopsy and what you may miss out on, perhaps for not having a bone marrow biopsy, but that's a calculation that sometimes is personal. Some patients really want to know, and some patients are like, I'm okay. I don't need to really know that. It's not going to change how you treat me. So feel free to ask. All right. Now, what about you're going to have that bone marrow biopsy, but you're really worried about pain? How do we minimize pain? All right. So the first bone marrow biopsy is usually the worst one. And hopefully most of the folks that are on this call, if you have an MPN or one of your loved ones has an MPN, hopefully it's one and done. So keep that in mind. After somebody's had one bone marrow biopsy, the next ones are easier, I would say, because they know what to expect. So not super helpful, but just something to know. We usually will place the patient on their belly, so they're lying face down. We put an anesthetic, kind of similar to what you get when you go to the dentist. In the dentist, they use Novocaine. We use lidocaine, but it's all canes. It's all types of numbing medication. So numbing the skin, that can sometimes burn. And then they numb the surface of the bone. It does not block the pain of the aspirate. The aspirate, when the doctor fills the needle or the nurse practitioner fills the needle, the syringe with the aspirate, there's a feeling of like pulling. And I feel like patients can really find that very uncomfortable. Unfortunately, there's really no way to numb that because that's the inside of the bone, but that only lasts like a few seconds. So a person that's good at doing bone marrow biopsies will warn you and say, just take a deep breath or take a second, just brace, it's just going to take a few seconds. Some patients really, really find that very, very uncomfortable, but it thankfully only lasts a few seconds. Now, pain tolerance varies widely from patient to patient. There are some patients that don't feel it at all, are not bothered by it at all. And then there's some patients that really find it terrible, and nobody's right or wrong. It's just people experience pain in different ways. Some patients have frailer bones. The bone marrow biopsy is easier. Some patients have really hard bones. The bone marrow biopsy is hard. But hospitals can provide things that really do help with the anxiety of the procedure. I think that being informed about what a bone marrow biopsy entails also hopefully helps. I also think it's really important, and unfortunately that's not very helpful advice, but I'll say it anyway, an experienced operator is crucial. If you go to a place that does bone marrow biopsies every single day, multiple times a day, and that person does, over 10 bone marrow biopsies a week, it's very different than if you have a practitioner that's rushed, that only does a bone marrow biopsy a month or less than that. And so the experience can be very different depending on where you get that bone marrow biopsy. And I wish that everybody could have access to a place with a lot of experience. If you're going to be referred somewhere for a second opinion, folks, this is really important. If you're being seen by a practitioner that's not super comfortable with these conditions, don't get the bone marrow biopsy there. Get the bone marrow biopsy at the place where you're referred. And I'm not saying that to be snooty or anything like that, but if you have the opportunity, not everybody has this, but if you have the opportunity to go to a center that does a lot of bone marrow biopsies, just get it done then. Remember what we're talking about. Most people only need one bone marrow biopsy. So not only will that bone marrow biopsy be less painful because hopefully you're getting it done by somebody that's more comfortable, but then the pathologists that have tons of experience looking at these bone marrow biopsies will get an opportunity to review your bone marrow biopsy as opposed to a pathologist that doesn't really see these diseases that frequently. So that would be another piece of advice. When folks are having a bone marrow biopsy, besides the local numbing anesthetic, they also have the option of getting other medications for pain and for sedation. So what are the options? So everybody gets that local anesthetic. So that's the numbing medicine in the skin, the numbing medicine in the bone marrow. And then sometimes patients will get a tablet of something like lorazepam, also known as Ativan. People stay awake, but it just kind of cuts the edge off. I would say that's the most common thing that we utilize in our hospital. Sometimes patients will get it IV. Occasionally, patients will get that medication, the anti-anxiety medicine, with also a pain medicine like morphine or something along those lines. Most of the time, these other things I included just because for completeness, some facilities, not all facilities, will do like actual sedation. You need an anesthesiologist, that kind of thing, with medications that really do get you to sleep. I will tell you, and I don't mean to sound, I hope I don't sound like I'm not compassionate, but if you have an experienced practitioner, most of the time in that practice, that type of sedation is not necessary because the docs and nurse practitioners that do those biopsies are so experienced that with a lot of good local numbing medication, most patients actually make it fine. And I see dozens of patients going through bone marrow biopsies every week, so I really am saying that by experience, even though, of course, it's easy to say that when you haven't done a bone marrow biopsy to yourself or hadn't had a bone marrow biopsy done yourself. But our experience in clinic is that most patients are really able to have bone marrow biopsies like this. In our clinic, for example, we'll have music, we'll even have like some aromatherapy, other things to just make the environment there a little bit easier. And it sounds trivial, but it actually makes the whole experience just a little bit better for patients. They're more relaxed. And I think that goes kind of a long way. And it's not that I'm not in favor of having sedation if it's available to you, but anytime you take an extra medication, there's extra risk. You have to take more time off of work, those kinds of things. So I think it's important to just think about everything with the pros and cons. Of course, there's patients that'll have special circumstances that require different things. So there's different options available. You always have a right to ask. You have a right to ask, why do I need this biopsy? First and foremost, you have the option of asking, can I have pain control, or what are my options for pain? And remember, each hospital, each clinic is really different. So just because in one place they tell you one thing and in another place they tell you something else, doesn't mean that one place is doing it right and the other place is not. Just there's different practices in different places. Like I said, where I work, we do tons of bone marrow biopsies. Most of our patients will get Ativan or nothing at all, but they get lots of numbing medications, the music, the aromatherapy, calm environment, very experienced providers. We haven't felt like our patients really are asking for more pain meds. Occasionally they do and we give them, but maybe in another practice that's different. Maybe they say, all of our patients have conscious sedation and we send our patients to interventional radiology, for example. So there can be different practices in different places. And just ask, what's your practice? How many do you do? How do your patients do? What do most people take? Does everybody take pain medications? Those kinds of things. And then when you're having the procedure, I tell my children this. If you don't speak up, your teacher can't read your mind. Same with the doctors and nurses. If you're not comfortable and you don't say that you're not comfortable, folks won't know that. And so it is okay to say, hey, take a second. Whatever you're doing right now doesn't feel good. Can you give me some more numbing medication? Totally okay to do that. Just don't jump out of bed. You may have a needle in your back. So no jumping, but definitely speaking. You can always ask for different things, etc. And like I mentioned, usually if you're somebody that needs more than one bone marrow biopsy, that first bone marrow biopsy is usually always the worst. After that, you know what to expect. And so you can go to the second bone marrow biopsy and say, hey, you know, my first experience, this worked, this didn't work. Can we do more of the thing that worked to help make the experience more comfortable for you? And that helps. More communication always helps the care team take better care of you. And everybody's different, like I said. So some people need more than others. That's all right. Make sure you have somebody to drive you home. Some people are able to drive home, but not everybody. And maybe, you know what, you just don't feel like driving home. You just had a needle in your pelvis. So make sure you have a friend that can bring you home if you have that available to you. Okay, so we've kind of talked about this. So ask about what options are available. You can ask about that in advance. You can ask about what medications you need. We talked about the ride home. Talk about aftercare. What can and can't I do after? Can I take pain medicines after? What do I do if it bleeds? Who do I call? All of those things I think are really important, because after you have the bone marrow biopsy, you want to make sure that you're ready to take care of yourself at home. Most people will be sore. They maybe need to take something like ibuprofen or Tylenol. Most patients do not need to take medications that are stronger than that. But you know, if you felt like the last time you had it, you needed something else, it's important to ask so that the people that are taking care of you can be prepared to take care of you afterwards. And then how do I get results? Is somebody going to call me? Do I need to call somebody? Do I have an appointment to go over the results? All of those things, really important to ask. And if you have the opportunity to ask before the bone marrow biopsy visit, even better, because you're probably going to be nervous that day. And I always think it's nice to have a support person, whether that be a family member or a friend, to maybe, record those answers for you so that you don't have to be worried about remembering things, or where did you put that piece of paper where you had that information with the phone numbers and those kinds of things. What about the future? Are we always going to need to do bone marrow biopsies? Man, I hope not. So for a lot of oncology, actually there's, and you probably read this all over the place because it's so, catchy. What is this liquid biopsy? So for many solid tumors, we have this new term, liquid biopsy, where they will do blood tests and then get information about, is there a tumor somewhere in your body? But guess what? These are blood conditions. And so our liquid biopsies is already part of our practice because we get lots and lots of information from the blood. Most patients can find out if they have an MPN by doing genetic testing from their blood. And so we can look at the bone marrow, we can look at the blood tests and say, do you have the mutation? Do you not have the mutation? How much of the mutation do you have? That's called allele burden. And so we already get a sense of really what's going on in your bone marrow by looking at these tests in the blood. However, our blood tests now really can't see some things. Like, for example, we can't look at the architecture of the bone marrow. We can't look at the cellularity of the bone marrow. We can't look at how much fibrosis or scarring you have. We can sometimes miss if there's increased blasts because they don't always show up in the blood. And we can't always differentiate between the different subtypes, ET, PV, or MF, by just looking at the blood. But research is changing. And so I think with some of these more sophisticated assays or these tests, we'll be able to better distinguish the different conditions and get additional information that's not just the mutational information. So, right now when we do mutational testing, we look at DNA. We look at, is your DNA in the right order or is something off? And if something is not in the right order, that's a genetic mutation or a genetic mistake. And so that's what we do our test with now. But there are other more sophisticated tests that look at RNA, which is the in-between between DNA and proteins, which are starting to be utilized to say, like, if we measure all sorts of RNAs from a sample, that may correlate with how much scarring is in the bone marrow. AI, artificial intelligence, is everywhere, is better able to now put together information from blood counts, from DNA tests, fancier DNA tests or RNA tests, to say, oh, these signatures, these different patterns of RNAs equal myelofibrosis, or these different patterns of RNA equals ET. They're probably going to be way more accurate than our bone marrow biopsies. The downsides of bone marrow biopsies, in addition to all the obvious things, like it's a procedure, it's painful, it's invasive, and all those things, is that a bone marrow biopsy is a very small sample of all of your bone marrow. So sometimes we can do a bone marrow biopsy of one area and say, oh, this looks like a lot of fibrosis. And then you do a bone marrow biopsy in another area and it looks like no fibrosis. So it's not even. But these fancier tests actually are probably much more accurate at really saying, if we look at this signature, the pattern of all of these different molecules, this correlates with not a lot of fibrosis. And if we look at this other pattern, this correlates with tons of fibrosis. So these fancier tests that are being developed, some of them still sound to me like sci-fi, there's something futuristic that's never going to happen, actually are here. I mean, there's lots of different research studies, including these assays, are much better at accurately classifying people, and will probably help us to really more accurately be able to say, you have a disease that's really not likely to progress, whereas it'll be able to also identify patients that we say, you know what, we really need to worry about this person because maybe their disease is going to get worse very quickly. So there's lots of different trials, like I said, trying to understand these different tools, and I'm hopeful that in the future, we may not have to do bone marrow biopsies as much. And like I mentioned previously, I think there is an awareness now, both from the providers that take care of MPN patients, and of course from patient advocates, that we really shouldn't do MPN clinical trials in the same way that trials are done for other blood conditions. So I also treat patients with acute leukemias. For them, we need to do bone marrow biopsies about once a month, which is already very, very painful, very frequently. But for MPNs, we really don't need to do that. And so hopefully also increasing the awareness of the utility and the limitations of trials can limit how frequently bone marrow biopsies are done in clinical practice, but also for clinical trials. So are we there yet? Can we give up on the bone marrow biopsies? Not quite yet. I mean, I think there's definitely scenarios where we just don't need them. But I do think that in the near future, because of more sophisticated, fancier tests, we'll be able to either space biopsies further apart or give them up altogether. So hopefully in the future, we'll be able to say, remember when we used to do bone marrow biopsies? Now we really don't need to do that because these tests are so much more accurate, but we're not quite there yet. So don't forget, you can always ask your team, can you check these mutations or these tests by just looking at my blood? How will the bone marrow biopsy inform my treatment? And if the answer is not satisfactory to you, if they don't have a great answer about how that bone marrow biopsy is going to change your management, it's okay to say that you don't want a bone marrow biopsy. Absolutely. So key takeaways, a bone marrow biopsy is a special test. It's not done all the time. I recommend doing it at baseline to get a clear diagnosis, accurate diagnosis that then sets you up to be able to get accurate, treatment that's specific to your diagnosis. You can and always should advocate for yourself for pain control, and not just to ask for medications, but also to just understand what's about to happen, because I think that information is power, knowledge is power. So the more you know, the better prepared you can be for the procedure. And I think that can also really help you know what to expect so that you're able to tolerate this procedure better. And like I mentioned, blood-based monitoring is expanding very quickly. There's lots of really cool research out there, but it's not yet ready to replace all bone marrow biopsies, but the hope would be that at some point it would. So there's lots of really great websites out there. Of course, this is one of them, but there's the MPN Research Foundation, the Leukemia Lymphoma Society, now Blood Cancer United, MPN Advocacy and Education International, and of course there's the NCCN and a variety of other websites that are very helpful. So you can ask your care team about that. I think webinars like this are very helpful. Be careful with what you learn on social media. Remember, Sometimes when people post stuff is because they've had bad experiences. And so don't let that necessarily influence your decision making. It can be helpful in some situations, but remember asking your care team to give you good resources and finding information that's reputable, I think is really, really important. And thank you so much.
Awesome. That was wonderful, Dr. Hobbs. We'll hop into questions here in a second, but I really loved how you emphasized that patients have the right to ask and they have the right to say, you know what, this answer is not what I was looking for, and I'm gonna turn this down. I think so often in speaking with patients, they get a little bit of that white coat syndrome where maybe they don't feel they can really speak with their physician or with their care team and say, kind of, I don't want to say challenge, but ask these questions of, hey, why are we doing this?
Right.
So I think that's really good for everyone to hear. An expert like yourself say, hey, you can ask us questions. We're open to it. That's what we're here. So I think that was fantastic.
Thanks. And hopefully your team will be open to that. If they're not, then maybe you have to, to reevaluate that. But asking is always so important.
Absolutely. So we did have a couple of questions come in here. So this one comes from an individual who's saying, um, could you touch on the topic of quote unquote dry taps, especially in myelofibrosis?
Oh, sure. Great question. I'm sorry I didn't bring that up. So sometimes in patients that have myelofibrosis, and honestly, sometimes it just happens, we're not able to get that aspirate. So remember, the bone marrow biopsy has those two parts. So there's the core, where you just put a needle into the bone and basically get a tiny little cylinder of bone marrow. Everybody can get that. But the aspirate is where you put a needle into that, you put a syringe into that needle and you pull out the aspirate, that liquid sample of bone marrow. Sometimes when the bone marrow is very abnormal, when there's a lot of scarring, it doesn't allow the aspirate or that liquid to come out well. And so that's what we call a dry tap, where you just cannot get the liquid out of there. So we then end up having to get a lot of the information from just the core and the blood that we do from the blood.
I think that's a great answer. Next up, someone was asking about having osteoporosis and receiving bone marrow biopsies. Is that something that they need to be concerned about?
Great question. No, actually, it's safe to do with osteoporosis, and actually, it's probably less painful to do when people have osteoporosis because the bones are easier to go through. The practitioners are just a little bit more gentle, but they, whether they know or not, that's just something they'll like. It's not something that I would be too worried about. You can definitely mention it to the doctor so they know to maybe apply less pressure. But yeah, we can do that in patients with osteoporosis for sure.
And then next up was, are there any red flags that someone should be looking out for in the days following a bone marrow biopsy? I know you mentioned that they might get some light pain meds, but is there anything that they should be aware of, okay, this is concerning and I need to call someone now?
Yeah. So very rarely, but occasionally it happens. Patients can have bleeding after a bone marrow biopsy. And sometimes that bleeding is obvious. The gauze that they put on you or the bandage they put on you, if it's getting like really soaked through and you change it and it's still soaked through, probably call the clinic that did the biopsy because maybe they need to reevaluate you and maybe just put more pressure. But sometimes there can actually be more significant bleeding at the site. This happens very rarely. I would say less than 10% of cases. But if, as the practitioner is going through, the layers of tissue in the back, sometimes, and this just can happen, you can nick a little blood vessel. And so that can lead to lots and lots of bleeding, especially if somebody, for example, is on a blood thinner and they stopped it for the procedure and started kind of right away, or it's just bad luck and can sometimes happen. Sometimes people can really get a big bruise. And so if you're having lots and lots of pain, like you're having a hard time walking, getting up from a chair, those kinds of things, definitely call the clinic that did the procedure so that they can evaluate you.
And then our next question comes in and says, my husband was suspected of having myelofibrosis. 1 year later, he was shown to have ET. We are curious if, from what you have said, that he may still have myelofibrosis due to the location tapped. We have heard that just because you dip a pail in the ocean and not come up with fish doesn't mean that there are no fish.
Right. No, great question. That's unusual. Most patients are, it's the other way around. Um, so it's hard to answer a specific question. There may be some scarring in the bone marrow and they just happen to catch it once, but not the other time, or the other way around. I would say that in that situation, and that goes against a lot of what we've been talking about, but I would really go more by the blood counts, the mutations, and the symptoms that your husband may have, and that'll guide the treatment. Um, and so sometimes, we really want to do our best to say, like, does my patient, my husband, my spouse, whatever, have ET or MF? Sometimes it's hard to figure that out. In reality, they probably live somewhere in between those two. And so the clinical management really should focus on their blood counts and symptoms. I would say that if your husband has a calreticulin mutation, that makes even more sense because that's a mutation that lives on the spectrum of some scarring. Um, and so it may just be that your husband is just somewhere on that spectrum between those two conditions, and it may not make a huge difference in terms of how they're treated after they've done all this investigation. And so I would probably go by that and not necessarily repeat another bone marrow biopsy as a tiebreaker.
So, and I really like how you pointed out that we talk about PV, and MF as three distinct, but really it's more of a continuum, where patients may be kind of in between some
Right.
of these. And I think that that is an important distinction to make. So I really appreciate you pointing that one out.
Thanks.
And then this question probably doesn't apply quite as much for MPN patients, but I was speaking with an individual who has CMML the other week who was asking some questions about how long does it take for the bone marrow to recover following a bone marrow biopsy. This individual is getting pretty frequent biopsies. They do alternate sides, but kind of having repeated biopsies. We spoke a little bit about dry taps earlier, but that just, if it's done in the same general area over time, will that have an impact?
Should not.
Okay,
Yeah.
awesome. And I think that's gonna do it for questions. This was so incredibly informative. There is someone in here that said very valuable information. I wish I had a webinar like this before I had my first biopsy. So,
No. Thank you.
um, yes, so informative. And I think so much of the audience here today, but also those who will be watching this in the future, are really going to appreciate this. So thank you for your time.
My pleasure. Thank you so much for inviting me.
Of course. And as we're getting ready to wrap up here, I did want to remind everyone that a recording of this will be made available later this week. Um, and in that email with that recording, I'm also going to be sending out a survey that we invite you to participate in. This is designed um, in or we designed this survey with MPN patients. So it is for MPN patients, designed with MPN patients, and in collaboration with Dr. John Mascarenas, so an MPN specialist. So this is really for the MPN community. And this is looking at fatigue and MPNs. So it's tired of fatigue. Share your stories. And it's, I believe, a 15 or 20 question survey. So it doesn't take too long, but we really do value that insight. So I'll be sending that out in the follow-up email as well. And we invite you to participate in it. It's a wonderful way to get involved with research. And we do have a couple of upcoming events for this community. So tomorrow, actually, we will be having a community gather event. This is our community gather events are not recorded, but they provide an opportunity for patients to come together and speak with other patients. We know that not every MPN patient has another MPN patient living down the street from them. So this is an online group to just try to meet people who really understand what it's like living with one of these MPNs. We've got a fantastic group, and I encourage everyone to join if they're able to. Again, those are not recorded out of respect for privacy. So if you do want to be part of that conversation, you will need to sign in at the time. Um, then on Friday, we will have Mindful Yoga for Cancer Wellness, Restore Strength and Mobility with Jeff Abram. Jeff is actually a myeloma patient, so this is a really good event. He's also a yoga instructor and practices yoga daily. So this is really geared towards the blood cancer community and just kind of looking at how yoga can help with mindfulness, but also just get your body moving a little bit. So really encourage you to check that one out on Friday. That one will be recorded. And then next week we have our monthly cancer financial Q&A, expert questions to treatment costs and support. So this is part of our financial series. Again, that one will also be recorded. So I encourage you to register for those, even if you aren't able to attend, because you will be receiving those recordings. And finally, just another thank you to everyone for joining us today and for Dr. Hobbs for taking the time to give such a thorough and wonderful presentation. Um, that was honestly better than I could have hoped for. So you covered everything and more, and you did it so wonderfully. So I want to thank you all. If you ever have any questions or need to chat, feel free to email me. My email is dalton@healthtree.org. And as you're hopping off today, remember we do have that short survey that you can fill out to give some feedback about things you liked, things you'd like to see changed, or future topics. But with all that said, I hope you all have a wonderful rest of your day.
Thank you.
All right. Bye, everyone.